7 minutes time. As Somavo has another commitment, I'll request Somavo to start with intraoperative hydrodialysis repair, the beginner's guide. Somavo will start and then Onujit will go second. Yeah.
So very good afternoon all of you, and sorry to break the sequence. It will be upside down. So sound is. Oh, so certainly we have faced these situations in our early training days, and as a VR surgeon, I am regularly getting this type of cases where trainees are doing these maneuvers after removing the cataract. There will be a prolapse of the iris also with superior hydrodialysis. So my suggestion is please do not go for iris abscission in these cases. Very minimal instrumentation is required to repair these iris prolapses and hydrodialysis. Usually we found superior hydrodialysis, but you can find hydrodialysis in other parts, either traumatic or diabetic. How to manage and what we have as an instrument. We have just takes the polygraphy suture with straightening, medicine technique and one side. That's it. So I call it iris in crisis. So this case was referred to me by a cataract surgeon for post-cataract surgery, fixed dilated pupil after pilocarpine for 1 month. Also, this dilated pupil was not constricted and patient was complaining of glare. So 2 side ports and 1 straight needle is introduced through side port with viscoelastic in SC. And 1 I am showing very slowly. Okay, just very simple. We have to pull the pupillary margin, and we have to introduce the straight needle from upside down in the first. From up to down in the beginning. These animations are done by my student Dr. Shantan Manna. A very good artist. Now you have to pass this suture to the other side from down to up. This is very important. Up and down to up. And now you have to exteriorize this straight needle and the thread to the opposite side. Now this thread is divided into 4 contact points into 5 zones. So we can number it like from left to right. 1. So this is the thread. 1, 2, 3, 4 and 5. These are the 5 zones. So the second zone is very important. Just watch it. The second zone is very important because the second zone thread you have to exteriorize through the right-sided side port. So now with the maxillary forceps, I am exteriorizing the second part of the thread. Part makes a loop outside the anterior chamber. So the white part is a loop and the 5th part is already outside the anterior chamber. So this 5th part you have to introduce through the second part 4 times. This is called 4th row. This is 1, 2, 3 and 4. This is the 4th row. And when you pull the to extreme part of the suture, the knot will be interiorized with the constriction of the pupil. There's a little bit gap, just ignore it. This is my fault, but this can act as a PI also. So like this I have done more two single pass pupilloplasty in the other region. So you have to cut the suture ends. That's it. So like this I have passed the suture, more two sutures superiorly and laterally. I'm just fast forwarding this. Same thing. So this is the superior part and this is the lateral part. This is the final result like this. Second is iridodialysis repair hangback technique. So this is iridodialysis that I have shown in the very beginning. We have to rotate the iris and we have to make the iris in the final physiological position before repositing before fixing. So after iris atrophy, this is very difficult. This will mix with the vitreous. So vitrectomy and partial thickness scleral flap and then railroad technique. Just introduce a 26 gauge needle to the root of the iris and introduce the same 20 straight needle with 20 tolling and pass. You just need lots of patience, not a lots of skill. So it will make a loop. We have to make sure that by when introducing the side straight needle through the side post, you should not take the iris tissue inside the needle. So this loop will close the iris loop. Another suture I am passing because the iridodialysis is very large. Final tie should be at the end because if you tie in the very beginning, iris shape will be distorted. The same thing. Only in very deep seated eye it is very difficult to handle this long needle because it will create a mechanical disadvantage. That's it. So final tie is in the end after balancing the iris shape. And the knot will be inside the partial thickness scleral tunnel. So we have started like this. This is the final result. So these are the two techniques. It is very easy. There are multiple techniques you can try. So these two are very commonly you have faced. Thank you.
AV team, can you just check if the presentation is visible? So at the very outset, I would like to express my sincere gratitude to Dr. Shogota sir for including me in his IC as well as to AIOS for this wonderful opportunity to speak to this August gathering. So I'll be speaking on tackling faulty wound constructions, and I'll show you a couple of cases in which my wound construction went from bad to worse. But it's important to remember that a wound should ideally, in case of side ports, be biplanar, and in case of main ports, be almost triplanar. That allows a self-sealing incision with an appropriate length of near 1.5 to 2 millimeter, and in the correct location, and we will discuss what the location is with minimal corneal distortion. So this is usually how I like to conduct my incisions. And the technique may vary from surgeon to surgeon, but I guess the basic idea remains the same. After doing 2 side ports, I usually inject trypan blue and then do a main port incision. I've frozen this section just to show the nature of the triplanar incision that is usually done. So sometimes I get a question on what the incision size should be. No matter what your incision size is, this is the same thing which is done with an even smaller 2.2. The first one was done with a 2.8 incision. It is nearly the same way done in most cases. What is important to remember is that your incision should not change or should not vary too much from case to case. The closer it is, the better the closer it is in each kind of case, the better it is for you. The ideal incision should barely nick the limbal vessels, should be peripheral, far away from the visual axis to induce least astigmatism, as well as have a self-sealing nature overall. So why do we choose the limbus? The temporal limbus is actually the furthest away from the visual axis and also induces the least amount of astigmatism. Also because most of our patients also present in elderly age groups with against the rule astigmatism, a temporal incision works well for them. Maintaining good symmetry, the only thing I would like everyone to look at is an equal distance on both sides as you're going in for the second plane of your triplanar incision is essential to make sure that your incision post-operatively, or at least intraoperative, especially in harder cataracts, does not leak when you take out the phacoprobe. So let's look at some of my mistakes and how we can learn from these mistakes. So this is what would happen if you are constructing a faulty wound. Look at me just with a slightly blunt instrument go in. So let's just count the number of times I'm going to attempt this incision. Already 2 times have gone while I've spoken. This is time number 3. This is time number 4. So I am not even realizing that the instrument is blunt. So this is time number 5, and I'm well intrastromal at this point of time. And it has not occurred to me that either I want to change the blade, or I may be in a wrong plane, or I'm not dipping in. So if anyone is keeping count, this is close to time number 7 or time number 9 that I'm attempting the same incision through this. So the whole point of showing these mistakes is to know when to stop. You can see that the stromal cornea is also starting to reflect out, giving us the indication, but me as the surgeon is yet to realize this point. So we are at maybe time number 57 or 69 right now going into this incision, but it's still not giving away. Finally, the trypan blue has leaked out of the incision, but I've still not realized that the incision is not a full thickness incision. So the whole point of this is, number 1 is that recheck your blades, recheck what is happening inside. So this is after my rhexis. I decided to do my rhexis and then complete the incision, but I have not decided to change my blade. So this is something that can go wrong if you are not too careful. Okay, I'll just wait for this, yeah. So another reason why our wounds tend to leak is because we tend to over-pressurize the anterior chamber. This is a fairly simple NS2 grade cataract, but because I'm over-pressurizing the chamber during hydrodissection, you can see that there is a certain amount of iris prolapse. This is quite common, and we do see it throughout our operating life cycle, especially if we grade cataracts like this. But as we slowly burp out a bit of viscoelastic or repressurize the chamber, you can see that the iris goes back in. This is quite easy to handle overall. So this is a bit of dispersive followed by cohesive visco. Now, can anyone try and guess what went wrong over here? So this, you can see, is a Alcon blade which is going in. The wound seems absolutely fine. And first, during hydrodissection, the first time there is a bit of iris prolapse. I'm using dispersive viscoelastic, but not very smartly, if I may say so myself. Most of it is just leaking outside the wound and barely any of it is going inside. So now what has happened is that just like the case before that, the iris has prolapsed, but it's not going back in. So as I'm going in with my phacoprobe, you can see there's a bit of iris leaking out. So most likely this incision is slightly larger than what I expected during my initial construction. So the cataract extraction happens absolutely fine. And once again, I'm putting viscoelastic and just doing the cortical cleanup. And every time the chamber gets overpressurized, there is a bit of leak through the wound. So this is something we tend to keep ignoring as we do our surgery and attempt to finish the surgery as fast as possible. Now, notice here, Just as I put the lens in, everything seems fine. And as I'm doing the irrigation also, the wound starts to leak again. So does anyone have any opinion? I would also like to ask the panel, where was the mistake here and what could I have done to prevent it after the first time the iris prolapsed? So just to summarize, you want to keep a triplanar incision, maintaining a good incision depth inside as well as outside, having a good idea and a good knowledge of the limbal anatomy, especially in the paralimbal lesion, is very important in this case. And you want to look for your AC, which is shallowing continuously, iris prolapse, some amount of excessive wound leakage, corneal striae during phacoemulsification, which may cause your wound to become unstable. Thank you so much.
Presentation. So, any opinion from the audience about his question?
One thing, when you see there is a iris prolapse, first you try to decompress. Decompress, then if you want to put the visco, put it from the side port, because if you go on putting from the main wound, the iris will go on prolapsing.
So, the last case which you showed, was it a very short tunnel which happened?
No, it was an appropriate, it was slightly maybe short.
So, why was it?
Yes, the slightly oblique. If your thickness, you might not notice your thickness, so the iris tends to keep on bellowing out.
And what was the IOL pore axial length of the eyeball?
The action, it was otherwise a normal, no case of any drug usage prior to surgery or anything that would cause the iris to prolapse.
Number one thing, one has to manipulate the iris from the side port and put visco from the side port. And if extreme conditions are there, one can put a needle through pars plana and just put a cannula at the pars plana and a drop of vitreous will come, there will be hypotonia.
There are some cases of IF, floppy iris, there is significant number where there is no history of any drug, but that is also there in literature.
Yes,
It
exactly.
is a true picture of floppy iris without having any significant. So in one of your case wherein when you were entering with IA also, the eye
Yes,
was
that's
immediately-
exactly why I had that thing, because now the eye has been,
And there were slight progressive meiosis also, intraoperative, I saw.
Yes.
So that could be IF iris, rather
Yes.
than just wound construction.
some
No,
latent amount.
his entry was slightly oblique.
Slightly oblique, yes.
Thank you, Anujit, for
Thank
the
you.
lovely
Thank you.
take-home messages and presentation. Next, I'll call upon none other than Dr. Rudra Prasad Ghosh. Luckily, he is here. Otherwise, he would have taken all my patients when I am here. That's what he says. So, Rudra will be presenting on Rexis extension, how to manage. So, 7 minutes timer, please.
Good afternoon, audience. On the onset, I'd like to thank Dr. Sugata for including me in this presentation and the scientific committee to allow this IC2 air. So my topic today is managing Rexis extension during phacoemulsification, tips and tricks to complete the Rexis. So recognizing a Rexis extension, recovery of a capsular Rexis extension or radialization run out during phacoemulsification surgery is a crucial to prevent a PCR and vitreous loss, with techniques focusing on restoring the tear centrally, stabilizing the anterior chamber and reducing the capsular stress. Immediate management involves filling the anterior chamber with a dispersive ophthalmic viscosurgical device to flatten the lens capsule and prevent the tear from wrapping round to the posterior capsule. How many of the audience knows about Little's procedure, except Dr. Saurabh Sannal? But I know that everyone does a Little's procedure. I'm coming later. Key techniques for recovering and extending Rexis. Little's rescue technique, completing from the opposite side, creating a second relieving cut, tweeting the flap, and encompassing with a new Rexis. Precautions during subsequent phaco procedure. Avoid hydrodissection, minimize capsular stress, utilize dispersive OVD, change surgical approach and IOL emplacement. So starting with Argentinian flag. Argentinian flag sign is a serious complication during cataract surgery for intermittent white swollen cataracts appearing as a blue-white-blue pattern when the anterior capsule tears radially after staining with trypan blue dye. It occurs due to high lenticular pressure causing the capsule to rip towards the periphery. So I have named this video when the going gets tough, the tough gets going. Video, audio को close कर दीजिए. So this was a routine hypermature cataract, and I was using a 1.4 and or 1.8 sodium hyaluronate to do my rhexis, but the day was not mine and it got extended. So I was doing a hemi-rhexis on both the side with the help of a micro-rhexis forceps and micro-rhexis forceps, and I have to finally complete it with the 26 gauge needle. So how to complete the phaco? Here the nuclear procedure is mainly done in a supra-capsular plane to avoid stress on the torn part. And I do my usual crater and chop technique in these cases with the, and as I'm doing a bit anterior, I am using a dispersive OVD in this case. So it's a routine case, and for the sake of time, I will skip the steps. And rhexis of a white cataract can extend anytime. If you go through this video, I usually do my white cataracts with a 1.4 or 1.8 sodium hyaluronate, and most of my cases I do fairly okay with this technique and with these OVDs, but sometimes it extends. So what to do at this stage? It's going to the periphery. You have to stop and put some more viscoelastic, make the chamber fill, and rescue the surgery with the Little's procedure. What is the Little's procedure? You put the torn capsule, I think extending capsule towards the center more cautiously and avoid extending the rhexis margin not beyond the zonular attachment. So I am saved in this case. So my third case of a white cataract, some milky fluid is coming out, and you can see it's extending in the central part. So what I will do in this case, I will encompass the extending part of the tear within my rhexis. And again, a high viscous viscoelastic is saving in this case. There are other techniques. I know there are many other techniques, alternate techniques to rescue the case, but this is my standard technique. So the same procedure I will repeat here. So radial extension or Little's technique. As the capsular rhexis is performed, posterior pressure can cause the tear to extend radially towards the equator of the lens. If this occurs, the most important step is to resolve the posterior pressure by filling the anterior chamber with the OVD. When promptly recognized, the flap can be redirected towards the center using the Little's technique. The Little technique requires the surgeon to grab the capsular flap, and traction is applied in the same plane but opposite direction, which redirects the flap centrally. If this fails, redirect the flap, it is suggested to either complete the capsular rhexis from the other direction or to cut the edge with an intraocular scissor with the complete the capsular rhexis. So this is white, but this is not a white cataract, a normal cataract with grade 2 or grade 3. Here you can see that, see, it has extended. So I skipped some part of the video. I applied a viscoelastic and applied my centripetal force of the rhexis and completed. Another hiccup, now I have to apply the same technique here. And complete the rhexis. So another case, this was a Tory case, and this was a recording of a deferred life surgery in a state conference, and I was a bit stressed, and see at the start of the surgery, the nucleus, the rhexis was going to extend. But that was the only step where there was a hiccup, and I applied the same Little's procedure and completed the rhexis. So I'm skipping this video, but because the last video is a video shoot on a day when the day is not mine, but I still managed to do a phaco. Can I take one more minute? Yeah, it extended. So I put a cut with the microrhexis forceps, and what's the main thing of this video is that I had to do this thing 4 times in this case. 4 extension, 4 cuts, and at the end of the surgery, I have seen there was still a flap there. When at the end of the phaco, I could see. Again, an extension. For the sake of time, I am fast forwarding my video and want to show the final state of the rhexis rather, you can see. But I was still able to complete my surgery. Thank you.
Thank you, Rudra.
So take home message, rhexis may extend in an expert's hands also like Dr. Sugotopal, but don't panic, there are techniques to rescue. If you fail to complete the rhexis without a tag, there's way to complete the phaco. Thank you for your patient hearing.
So next I'll call upon Dr. Nitin Dhira. He's the chairperson of IAOC, scientific chairperson of IAOC. Thanks for joining this IC, and he'll be presenting on intraoperative IFs and small pupil. So any comments from Rudra's presentation? I think microrhexis forceps or Haldipurkar forceps are very handy, especially if you can use from the side port in the rescue technique rather than...
Yeah, I was quite stubborn till 6 months back, not using anything other than a 26 gauge needle. But for the last 6 months, I have changed my technique, and I am doing all this type of tough cases with a Haldipurkar forceps and a microrhexis forceps. Yes. And that was my mistake. The name of the topic is my mistake, so that was my mistake, not using an Haldipurkar forceps. Yes, sir.
Very high. Why can't we do phacorhexis? Initiate rhexis with using phaco tip, 10 or 15% power. It creates an opening in the anterior capsule, immediately sucks the fluid. It's more or less a foolproof way of avoiding a radial extension.
There are several other...
But then there is some catch. We have to stain the capsule very densely, anterior capsule densely in intumescent cataract. And when we are extending the rhexis with forceps, we take care that we don't put viscoelastic in the open part of the capsule, because it goes in the bag, again raises the pressure. Yes. Otherwise, it's a very good, foolproof way of doing it.
Yes, and you can also, with needle, you can aspirate fluid. You can iron the capsule with a spatula, and so there are several
one other
techniques.
thing is, preoperatively you can do YAG capsulotomy in the room.
Another thing is that if you have an extension sub-incision, it is always better to go from the side port with your hand to rescue, because the moment you go through the incision, more visco will come out and more tendency of the rhexis to run out. So thank you, Rudra, for sharing your pearls. Next, Dr. Dhira will be talking about intraoperative IFs and small pupil.
Thank you very much, sir. Thank you very much for giving me the opportunity to be the part of this prestigious IC. So I'll be talking on managing intraoperative floppy iris and small pupil in some of my case. So we all know that this is one of the condition which seems to be the nightmare for a cataract surgeon if it is in full color, of its full color. So this is characterized by, the entity is characterized by iris billowing and prolapse and progressive meiosis. So if you look at the causes, there are so many causes for this entity. Mainly it's because of the drugs for BPH, but it's interesting to note that some of the drugs which are the latest, which causes much less potency in the cause for IFIS, comparing the traditional drug, that is tamsulosin, and the risk factor for the severity of this entity is based on the inadequacy of dilatation along with hypertension. And there are significant number of cases which have been presented in literature where they are showing that without any history of such drugs, this entity can be there in intraoperative surprise, as an intraoperative surprise. So the management will be your anticipation, looking at the history, and then poor dilatation, some of the clinical clues that you are getting, and then if it is coming into your surgical intraoperative cases, then there are ways with which you can manage. So I'll just come to the cases. In any surgical, can you please give some sounds? So based on our skills, we manage based on our learning, based on our experience. But essentially, any predicament in the surgical challenge, what we like to see is having the option with minimal damage, we try to see. So we are starting with the case. Can you please give some sound? The sound is not here. So here, since the dilatation was good and the anticipation was not there, so in the beginning, we saw that some prolapse was coming. So what I usually do is I put sodium chondroitin sulfate along with hyaluronate in the margin of the pupil, along with phenocaine. And this works if the dilatation is good in most of the cases. Because this particular OVD is a stick to the surface of the iris and the pupillary margin, and it stabilizes if you are doing the surgery quickly. It gives you time, and even if it is happening again, you can come out and put the same thing on the margin of the pupil and the iris, and this works in most of the cases, at least I have seen, even in the surprise cases. And some of the cases where I am anticipating that this is going to have the severe, then I used to give the patient pre-op atropine at least for 1 week. So this is the normal ending. This is the second case where the dilatation was even poor, and I had kept the patient for a week on atropine sulfate 1%, and then the same thing I will just put on the margin and the pupillary surface the viscot properly, and I'll start doing the case, keeping my tip away from the pupillary margin. You should not disturb the pupillary margin or the iris in entire your process of surgery intraoperative management as far as possible. And if you are seeing, once you are seeing that the pupillary margin is coming to the tip, you again come out and put little more viscoat on the margin. It is stabilized and it works. Because in the era of the EDOF and the presbyopia correcting lenses, if you keep on putting the iris expander or hook, they will cause permanent damage to the pupillary margin and disfiguration of the normal pupillary dynamics, which will have a bearing on the final result and the outcome. So mostly we should try to avoid the pupillary expander or iris hook, lifting the iris margin with the irrigation, and you can do the cortical wash and put the lens. So the last case which I want to show, this is the case, this is the full dilatation, and this is a myopic wherein the fibrous band is there inferiorly, and the biometry profile, if you'll see that axial length was 28. Patient chose for eye-hands, and I have tried to finish the case with minimal, the pupillary damage, the collateral damage over the pupillary margin. Of course, I need to cut the fibrous band to get little more dilatation, and the final result, because it was quite meiotic preoperatively. So the case, the challenge was little because the case was little more myopic. So in this case, I am using microrhexis forceps to have a better grip and hold on the margin of the rhexis. So once you have entered, with the normal fluidics, we can try and finish the case with the minimal injury to the margin. So in this case also, to prevent the pupil to come to the phaco tip, I had used viscoat along with phenocaine to get the maximal dilatation, whatever possible. And then I put the lens into the bag. So this was the post-op day 1. So to conclude, what I want to say that, of course, we should rely on our skill and experience. But at the same time, in the backhand, we need to prepare, we should prepare for the worst also. And all the armamentarium which are possible, and with the experience you have, you should have those things. Better communication with the colleagues in some of the forums wherein you can discuss with the urologist about the side effect profile of these drugs and the drugs which having minimum side effect profile. If the patient has not phakic, then this could probably work. Follow the science and learn from the experience. Thank you very much.
For the lovely presentation. Any comment from the audience? Any pearls from the audience? Quick pearls. Isco, can you please get this? Thank you. So, yeah, any comment?
Nitin, the first and second case, why don't you put iris hook or pupil expander?
Again, as I said, sir, because the iris hook or pupil expander, they damage the sphincter. So in the era of the premium lenses, and when we are considering the contrast and so many, we are trying to give the best visual experience in any of the lens. If the pupil size is more, the image quality goes down. So as much as possible, if we can do the cases without putting the hooks, any expander or the hooks, we should try to do, I believe so.
Okay. No, but yes, but the process during surgery, if it is touch the pupillary margin phaco probe, that will
Then the
get
last
more.
resort is always,
Yeah.
then last resort is always hook or the expanders. Thank you.
Yeah, one small input is patient on tamsulosin. It's better not to stop because even if you stop, it's
No,
not
there is
going
no
to-
point stopping.
So talking to the urologist will not help.
The
actually.
other option is there wherein the urologist in general can prescribe these drugs for alpha-jocin. This causes 40 times less potency for causing IFIS compared to tamsulosin.
Yeah, unfortunately, a lot of antihypertensive and lot of other medications
Yes.
also cause IFS.
Non-specific beta
So
blocker.
stopping any medication or changing it doesn't help. We need to.
We get over exuberant and we try to pull it till the end, That's when you get the sphincter test. You can actually see when you're getting the sphincter test when you're pulling it, So if you just... Yeah, that I agree with you, yeah. But it makes it so much more safer to, means otherwise you get a PC rent in these cases, Let's look at it that way, It's that way. Yeah, thank you.
Thank you. So I'm Dr. Suwato, and I'll be sharing a few of my PCA cases where I caused the mistake and how I managed it. There is no sound. There is sound in the next one. Yeah.
Last few PCR.
So this is a case. You can see if you look at the phaco time, it is quite high, 32.70. So it's a quite dense cataract I have managed, and I am on the last piece. So it's a thick lens. So see what I'm doing, what I could have done and what I'm doing. So there are several options in managing this. So I could have done IOC scaffold, I could have put visco in the anterior chamber to minimize the chattering, and I could have put the second instrument below the phaco tip to prevent the PC. And I did none of this actually. I did none of this. I'm carrying on with my phaco, and what happened here, you can see I have touched the capsule and there is a rupture. So there is a rupture. So what I have done right is, as a knee-jerk reaction, I have not taken my phaco tip out and maintained the chamber, put in visco, and there was no vitreous loss. So any irregular tear, if you can convert into a PCC, see, then your life becomes slightly easier. So that's what I'm attempting here, to convert the PCR into posterior capsular rhexis. And there was some movement from the patient's eye, and at the end, there was some vitreous loss, but I have managed to do a PCC. Once you have done that, you can do vitrectomy, and once vitrectomy is done, you can do staining with the tricot as I've done, and there is few stain which I am again cutting, so I am making the chamber free of vitreous. So once you have done that, chances of post-operative CME is less, and you can put the IOL in the bag as it happens in this case. So I was lucky, my mistake was there, but I have managed. So coming to my next case, there was, you can see there was an anterior capsular extension there. And I'm carrying on with my IA, and then I realized, oh my God, it has become a posterior wrap-up tear. Again, no knee-jerk reaction. What I've done, I've left my irrigation there, filling in the chamber with visco, and what I'll be doing next is, there is this irregular flap. So this portion is quite round, so I'm rounding this off. This irregular flap, I'm rounding it off, and still there is no vitreous loss. So I'm quite lucky, in spite of everything, there is no vitreous loss. So that is done. Now, unluckily, my assistant has already opened the IOL. So I'm thinking of my mind what I can do. It was a preloaded IOL which is open. So the extension is there, and my incision is exactly opposite to my incision. So what I did, actually I changed my side, and I've gone in from the other side, and now I know there is quite good space to put the IOL in bag, quite good space to put the IOL in bag, and if there is no vitreous loss, my day is saved. So once I got this situation, you can see this remaining of the rhexis is there. You have to be very gentle. You have to allow the IOL to open very gently in the bag, or sometimes you can put it over the anterior capsule and just nudge the haptic inside. So either of this works well. So that's what, in the trailing haptic, I put it on the iris and just manipulated under the anterior capsule, and again my day was saved, and I checked for any vitreous loss which wasn't there. So my next case here, I am doing hydroimplantation. It's a second eye of a patient who has VBT in the first eye. Now if you can see here, because there was little bit of astigmatism, I increased the wound. And you can see there is leaking of fluid from the wound. So once there is leaking of fluid during hydroimplantation, the posterior capsule can come up. But I didn't realize the mistake. You can see there is fluid there, and I am using a push injector here. Because of that, everything is going on. I'm doing it very slowly, but at the end there is a sudden jerk and my capsule is gone. Again, what I'm doing, I'm supporting the IOL. I'm not taking the irrigation on. Supported the IOL, then put the visco under the IOL, and then I'll assess the damage. And I can see that's where the rupture is. These are the remnant, and here my leading haptic has gone in the bag. So what I have to do, I've seen, again, there is quite a bit of posterior capsule. I have to just nudge this haptic in to save my day. And again, I was lucky, in spite of PCR, there was no vitreous loss. And I have just nudged the IOL in. You can use Y pusher as well, they are quite handy. And once I've nudged the IOL in, I have positioned the IOL. In this case, I tried to do capture, anterior capsule capture, but I failed, but it was quite stable. And this is my 2 weeks after the things. The eye well is stable and the pupil is quite in center. So my day was saved. So you can see the eye well is quite in center, and this is after a couple of weeks. This is the rupture area and the eye well is in absolute position. So these are my 3 cases which I thought I would share with you. Thank you. Any question? So I will, Dr. Swati Agarwal couldn't, I use viscoat or any similar in this situation. But sometimes if it is not open, immediately I use the visco which I have at that position. And how do I? No, Dr. Swati Agarwal, she is not here. So I'll be sharing her presentation on intraoperative hard eye. With voice sound, please.
Intraoperative hard eye. This video showcases 2 cases. The first about how to identify intraoperative hard eye and managing it. The second about the implementation of learnings. This patient had glaucoma and a drug history of tamsulosin intake. The incisions were made a little narrow and corneal. I noticed an iris flutter at the time of giving oculin, and then the iris started prolapsing. I thought I was going to land up with a floppy iris. So I injected viscoat and initiated a rhexis. But the iris went on prolapsing and the AC was becoming shallower. The globe was becoming firm. I paused and thought over all the causes of shallow AC. There was no leak or high AFR to cause excessive fluid outflow. The bottle height and the fluid inflow was adequate. The speculum was not tight. Neither was there any retrobulbar hemorrhage. So I had an intraoperative hard eye, which could be because of suprachoroidal hemorrhage or effusion or fluid misdirection. This picture here shows how the fluid is trapped behind the zonulocapsular diaphragm, and subsequently the iris and the lens body has moved forward, resulting in a shallow AC and hard eye. Resuming the case, I found that the AC went on getting shallower, the cornea became hazy and whitish, and the eye was gradually getting harder, so hard that I could no longer inject viscoelastics or reposit the iris back. Mannitol was infused and sterile IO done to rule out suprachoroidal hemorrhage or effusion. I now knew that I had landed up with an acute intraoperative rock hard eye and needed a different approach. After an hour, though the cornea was slightly clearer, but the eye was still very hard. Pars plana aspiration of the vitreous was done with the cutter in full visibility, simultaneously palpating the hardness of the globe with the other hand. Alternatively, a pars plana vitreous tap of 0.1 to 0.3 ml could also have been done. I now had a softer eye and a clearer cornea. Rhexis could now be easily completed. Phacoemulsification was done and iron was implanted in the back. Finally, I had a happy patient and a happy surgeon.
I again had a similar case a few months later, but this time there was no iris flutter at the time of infusing fluids. But trypan blue oozed out from under the iris, which I had to wash again. At the time of giving viscoelastics, the eye started becoming hard The cornea was becoming hazy and iris prolapsed. I loosened the speculum and asked the patient to breathe in through the mouth. With my previous experience, I now knew that I had too hard, rock hard an eye. I had by now learnt my lessons. With much effort, I was able to reposit the iris back. I tapped at the opposite paracentesis wounds to displace the trapped fluids from underneath. But the eye was still too hard. Ultimately, I planned to infuse mannitol and the patient was shifted to ward for an hour for the mannitol to take its full effect. When the IOP slightly lowered and the cornea was slightly clearer on slit lamp examination, I resumed the case. Rhexis was completed and gentle hydrodissection done with tapping of the nucleus. The nucleus was rotated. This time, viscoelastics was given over the iris to prevent the fluids from going underneath. Phacoemulsification was done. Cortex was aspirated with bimanual IA. IOL was implanted. Cornea was now much clearer. So finally, I could say that.
Arup, I would just reverse the thing. Just tell me one thing. Is there any possibility of, sorry.
But the eye.
No.
Ultimately.
There was some. There. Is this anything?
But
you can see
Trypan
this dye coming
oozed out
out.
from
Is
under
this
the
sign
iris,
of
which I
zonular
had to wash
weakness?
again.
And could have been the visco going through there to do the intraoperative hard eye. Any idea from any comment?
At the time of giving viscoelastics, the eye.
Yeah.
Cannula, we always have this 23 gauge Tokar cannulas, and your cutters which you'll have with your anterior vitrectomy is 23 gauge. So in a patient with shallow AC, or a patient who has a relative anterior microophthalmos, or a patient who has a power of 27, which you expect a shallow AC, so I pre-op do this procedure. I don't do it later on. So I can maintain the depth and create a deep AC by just doing a pars plana vitrectomy, which is a single port vitrectomy which you showed. And then you keep on injecting viscoelastic to make the AC deep. And then your case becomes very easy in an intumescent cataract also,
Okay.
So as a retinal surgeon, we do it. And I think these Tokar cannulas are now freely available from Oro Lab, and they're 23 gauge. So you can have a tunneled incision and it becomes sutureless.
Thank you.
Thank you.
Yeah. Oyon, you want to get ready with your presentation?
Yeah. One small point, like if you look at the amount of fluid which was being injected and the amount of visco which is being injected in this particular case, it's way too much. So in these small eyes, less is more. So if you inject just a little bit, and in fact, even when you're going in with the phaco probe, you should go it with everything off. You put the phaco probe inside and then you turn it on so that you minimize the amount of fluid in the eye. You'll be able to manage these cases much better.
This is very relevant. Whenever we see the very high adapter lens, hypermetropic, say 34, 35, we thought we overinflate. Tendencies.
And he will be sharing his misfortunes with the IOL. And this can undo the good work which you have done. So you have to be careful while injecting IOL. So, Oil, please.
Thank you, Sugato, for inviting me to this course. I'll be talking on managing IOL-related complications. So, it's a video-based presentation. I have a few video clips to show. So, I'm injecting the lens, and then when it goes in, I saw the haptic is torn and is lying outside the wound. So this is a very, very common complication that happens sometimes. So what you have to do is have to explant the IOL and then reimplant another IOL. So you have to have a backup lens. Sometimes it's required. So it's torn completely. So you just divide the lens into two and then take it piece by piece, take it out and then reimplant another lens. So this is the next case in which while I'm injecting the lens, I didn't notice anything, but once it is in, I saw again the haptic is torn and this time it is lying inside the injector. So again we have no other option other than cutting the lens into two pieces and taking it out. So this is another video in which a Rayner lens, you can see it is going in, is a Rayner toric lens. And part of the haptic is still within the cartridge that is stuck. So you have to refill the chamber with viscoelastic and pull it out. Oftentimes you may not be lucky and you have to, sacrifice the lens because the haptic might get torn. If you feel that the lens is not going to be stable in the anterior chamber, you have to explant or else you can keep it in if you think that the centration is going to be maintained. So this is another video in which while I'm injecting the lens, it goes in again, the trailing haptic is within the cartridge. So many a times this is a loading problem. In our institute, the assistant loads the lens for us. So if you can load it yourself, I think that's a better idea. And as you can see, this is a premium IOL. You can see, as Shugat already showed this video, that the sudden shooting of the lens from the cartridge is a frame by frame. As you can see, it is going in and suddenly you see a jerk and the lens hits the equator of the bag. So this might lead a tear of the PC as well as the anterior capsule, and the lens might go into the vitreous cavity. So you must be very careful while injecting the lens. If you feel certain amount of resistance, go very slowly to inject the lens in. This is another lens again. It goes in suddenly, but this time unfolding, the lens is not unfolding and it has become a single rolled unit kind of a thing, and due to the fluid turbulence in the anterior chamber, it rotates. At this point, it's better to put some viscoelastic and manipulate the lens. So I had to struggle a lot in order to make those haptics free. So these are some occurrences which happen in our day-to-day practice. So again, this is another Rayner model lens which I am injecting, and this particular lens has a peculiar habit of flipping. It flips very often, and before you realize that it is flipping, you can't do anything about it. So it flips inside the anterior chamber, and it's a toric lens. You have to correctly orient it. You have to put some viscoelastic in, and with the help of two instruments, you just reflip the lens into the correct orientation. So while doing so, you must be very careful of not injuring the endothelium. So you put adequate amount of dispersive viscoelastic to coat the endothelium before doing the flip.
I'll stop you there for a second. So if you have a situation where you are using hydroimplantation, would you come out and put visco while flipping, or you will carry on with the flip?
And that's what I told. It's better to put some viscoelastic in before. Obviously, before flipping, you have to put some dispersive viscoelastic to protect the endothelium.
So
otherwise, don't try.
If you do it rightly, it will not touch the endothelium, but probably it is better to put Another thing, when the haptic is stuck, you can rescue it by giving a cut with the keratome on the cartridge, that that actually prolapses the plunger and the haptic become loose.
During hydro implantation, it's a...
Yeah, I have two cases where you have to change your, obviously, you have to take your hydro out and put visco from the side put and there. Thank you, sir.
But if it comes out, if you pull it out, and then I think
Yeah.
if you try to cut the cartridge, what might happen is it might injure the haptic as well.
No, you have to give a cut in a different area of the cut. Thank you.
So this is another lens. Again, the haptics are sticking to each other. Again, it's rolling, and you have to take a second instrument in your right hand, and then separate those haptics. Sometimes quite a lot of effort goes in for the separation thing. So this is another case in which the haptic now it gets stuck to the optic, the body of the optic. Especially if it sticks to the posterior part of the optic, it becomes even more difficult to separate them. So again, it's better if you inject some viscoelastic and then try the maneuver. Now this is another case in which while I was implanting a multi-piece lens, I saw there was one of the haptics was broken. So this is the axis of multi-piece lens. Again, while I'm injecting the other lens, the next lens that also again got broken, I increased the size of the wound and did the third lens implant. This is the third one. But probably it was not the fault of the wound. It was a fault of the haptic. At one point of time, the axis of multi-piece lenses used to come with very brittle haptics. I think those were, yeah. And yeah. Okay. So this is another instance in which part of the lens gets stuck to the wound, and now you're at a dilemma whether to push the lens in or pull it out. So here in this particular case, most of it was inside, so I decided to push it in slowly and gently. But if it occurs in a 50-50 position, it becomes a problem. So it neither tries to come out nor you can push it in. And especially with hydrophobic lenses, they become very stiff, and they are not quite malleable at this stage. It is very difficult and become very hard. So I have to be very careful, gently pushing the lens in. Thank you very much.
Thank you, Ayan. So for sake of time, we'll call Dr. Arup Bhaumik to show intraoperative zonular dehiscence management. So,
can I have two questions?
Yes.
Or suggestions?
Yeah.
For the first one, the Rayner toric, if that lens is not vaulted, you didn't have to flip it over, which was actually unfolded other way around. You could leave it, you just keep the orientation for the toric, leave it there. If there is a EDOF or something where it posterior modification or anteriorly vaulted haptic, then you have to flip it over.
This Rayner toric lens is an EDOF lens.
It is a EDOF.
EMB.
Okay.
EMB.
Sometimes EDOF things. And the last one, when it got stuck in the wound, just get that 15-degree tablet which you use for the side port, just surfacing on the edge, the blunt edge towards the lens, you just increase the incision a little bit and it will easily go. Just keeping in the mind that the blunt edge towards the lens and the other edge, you can just, a little nick, it will be easy.
You have to use side port for blunt edge towards the...
No, no, the side port, the knife you use for the side port, which is one-sided sharp, one side
Yes.
blunt. So use that one, and keeping the blunt edge towards the lens surface. The other way, just cut the cornea a little, and it will easily go.
Yeah. But most of us now today's use MVR. Both have the cutting edge. Yes. Thank you, Shugato, for including me in your IC, my managing intraoperative. So intraoperative jonular dialysis probably the most commonest cause. It's happened during most of the time it is happened during cortical aspiration. The most of the time. It can happen any situation, but most of the time it is in cortical aspiration. Stages, rhexis, if you forceful completion of rhexis, your rhexis is just run out and you try to forcefully, then it causes jonular damage. Forceful nucleus rotation during the phaco, excessive force by the phaco probe, excessive force or asymmetrical force during nucleus division, excessive force by the chopper, cortical aspiration and implantation, IOL implantation, as Shugato also shows how IOL can damage capsulogenular complex. So I'll showing a few cases, and the strategies you should treat as a subluxation, nothing else. And how do stabilize the capsular bag? It's either capsular hook, or you have to implant CTR, or in extreme cases you may fix the capsular bag with Sioni segment or Ahmed segment or CTS segment. And timing of the CTR as late as possible, as soon as you must. So I am showing this case once again. This is a normal case, and you just whenever there is some kind of, just don't try to put, either you reposit the capsular bag at the position, and here you can see I am putting the reflux to release the capsular end, and again it comes some vitreous, so it is actually entangled with the capsular edge of the vein. Now you are putting the viscoelastic, and it is a time to put CTR, which actually stabilize the bag. If you don't satisfy the implanting CTR along, you can put one or two capsular hook. It will help to manage even better in case of jonular dialysis. This is another case. So I am doing the routine phaco, and it is probably I have to do a lot of cases one day at a stage. I am in a hurry, and there is an early signal. There is some kind of jonular. I am just ignoring this. I am just continuing my case. Thought I can manage this but I thought I just. Now there is a large jonular dialysis, and this is called, we presented this case, teach in time saves 9. Actually, if you put one single step during that stage, putting only one hook or CTR, you could have saved the case, you can manage the case much better way. So I'm putting the CTR instead of it's better to put a capsular hook, but I put the CTR. Now the CTR is trapped in between the epinucleus. And this is a very, very difficult situation, seriously. And now I am injecting viscoelastic with my second hand. This is a visco dissection. And now it's really, really difficult. One hard sheet of the nucleus is there, and there is a whole epinucleus. Somehow, with the continuous visco injection or visco dissection, I able to collapse some epinucleus into the anterior chamber. Once I remove most of the epinucleus, then the job is relatively easy. See this, after removing the epinucleus, I saw this the chunk of the nuclear fragment goes behind the capsule. So this is a very difficult situation, and there is a large jonular dialysis. I put a CTR and 2 chunk of nuclear please in the, now the very tricky situation, CTR in the bag, but I have to remove this. So I take a desperate attempt to make a posterior capsular rhexis and putting a lot of viscoelastic just put the visco to push the antivitreous face. Now just making a rhexis, able to do a quite a almost 2 to 3 millimeter rhexis. Now with the visco, I just retrieve the fragment into the anterior chamber, and yes, this type of maneuver create a lot of traction into the vitreous. I have to put a lot of vitreous. Now I am putting my blunt chopper and bring it into the anterior chamber. Keep the fragment over the iris. Now do the little bit of vitrectomy to not only remove, just to remove the viscote. Viscote is very relatively, if you put in the antivitreous postoperative rise of IOP will be very high, and put the IOL in the sulcus and capture the active. Now there is another case I am showing. This is a very hard and Morgagni cataract, and expected the jonule is weak. So as it is a hard, you can see that there is a faulty technique. You just see my right hand phaco-tip. To separate this, I am just putting the nucleus with my phaco-tip in the right side. You can see my phaco-tip. I am putting in the right side, and this causes some kind of jonular dialysis. So it's as a forceful nucleus fragment division. It is sometimes you can cause some jonular dialysis. And now if I continue this case again, then it will be a disaster. So it is better put up CTR now, because bag there is a lot of space in between the bag and the nucleus. The nucleus is almost bag is full of nucleus. Now it is putting one CTR. After implanting CTR, I think it is not sufficient enough. Then again I put some iris hook to support the capsular rhexis margin and continue the case, and it goes uneventful. Now, this is the last case I am showing. This is a very hard cataract, and this is a common phenomenon when you manage a hard cataract. I try to do a good job, and I am getting a great crack also. You can see this is a fine crack. I am able to move, able to create a. Now it's some kind of resistant to movement, rotation. But I ignore this. I continue this. You're going to see, and there is a capsular rhexis margin in the almost center part. Again, I just removing one quadrant, I emulsify. I just ignore the fact that there is some, I thought I can manage, and see there is a lot of resistance during rotation, and there is a jonular dialysis. Try to move. And now what to do is treat like a subluxation. Remove, put viscoelastic, put capsular hook, stabilize the capsular bag, and in continue phaco. Once you stabilize the capsular bag with the capsular hook, then it is not very difficult, because here the subluxation area or jonular damage area is 3 to 4 clockwards only. So once you stabilize that, you no need to stabilize the capsular bag with the sclera. Just CTR implantation is sufficient enough. So I am just completing one putting CTR in the bag. And you can see that the IOL is well centered. So take home message, if there is any kind of zonular damage during surgery, treat as a subluxated case. So this is a key. Thank you so much.
Thank you. Arup, any tips how you could have that hurt cataract, inevitable that we are doing too much of
See,
that?
I thought I debulked the central part sufficient enough, but it is not sufficient. Sometimes there is a dilemma. I thought if you make a big debulk, no, then it is sometimes there is a dilemma. You are actually goes deep to sufficient deep, but actually not. So it is always better to do a small debulk with deep debulk. That will actually help.
Yeah, you
if
had
you
a
give
video.
a big debulk, a bigger one, and sometimes you thought you are deep enough, but actually not deep enough.
I remember you shared a video of bending the phaco tip
Yes.
and doing a central debulk.
Yes, that's another way to how much you assess the debulk. Yes.
Yeah,
Thank you so much.
Any comments or questions from the audience?
Siddhartha sir, any tips, any pearls?
So in that case, I'll close the IC. Thank you to the audience for staying back so late. I hope you enjoyed. Thank you. Thank you so much.